So hello, everybody, and thank you very much for joining us. Great to have you here. We have with us today Rick Shander from Vanderbilt. And good morning, Rick. How are you?
Good morning. Thanks for having me. It's evening for your...
Thank you very much for joining us. It's a great pleasure having you here. Again, Rick was with us in Dubai a few years ago, and everybody was impressed with his talks and lectures, and he's a worldwide authority in this field, and we really appreciate your time with us this afternoon. So without really any delays, Rick, you have the podium. Please go ahead and start the talk.
Great. I'm going to see if I can share my screen here. Let's see here. I'll need to be able to, there we go. Excellent. Is everybody able to see my slides? Is that coming up?
Absolutely.
Great. So I'm going to talk about a disease which is, it seems to be increasing in prevalence in the United States, and one which our center takes care of frequently, this aspirin exacerbated respiratory disease. And I want to focus in on what we as otolaryngologists need to know and understand. So this disease was first actually described by Whitall in 1922, but it's frequently otherwise known as Samter's triad because Samter published on it much more aggressively in 1968. Other synonyms for it are aspirin exacerbated respiratory disease, which is what we tend to call it in the United States, or probably the more accurate term and how it's called in Europe and most of the rest of the world is NSAID exacerbated respiratory disease, or NERD. So all of these refer to a syndrome of asthma, rhinosinusitis with polyps, and a respiratory reaction or exacerbation with taking aspirin or nonsteroidal anti-inflammatory drugs. The other important point is that this is just one of several different forms of aspirin sensitivity, and it's a non-allergic type of disease, and we'll explore some of the pathophysiology later. But it's worth taking a moment to see that there are allergic and non-allergic forms of aspirin and NSAID reactions. In addition, some also involve cutaneous reactions, including urticaria and angioedema. But the one we're talking about is as highlighted here. This is a disorder of arachidonic acid metabolism, particularly the hyperfunction of the lipoxygenase pathway. Certainly, we remember that arachidonic acid, which is a membrane phospholipid, is metabolized through these three pathways, with the cyclooxygenase and the lipoxygenase being the ones talked about most frequently, with the cyclooxygenase forming prostaglandins and thromboxanes involved in platelet function, pain, and inflammation. Leukotrienes involved in other forms of inflammation. It's really this middle pathway that's been hyperactive. And if we look into that a little more, I'm not going to get too chemical in this because we're doctors and not biochemists, but that lipoxygenase pathway is mediated by this enzyme called 5-lipoxygenase, and its products are these three cystenyl leukotrienes, leukotriene C4, D4, and E4. These are products of eosinophils, mast cells, and platelet adherent leukocytes, which are all inflammatory cells. These platelet adherent leukocytes, I'll park that in your mind as well. I'll talk about that a little bit later. So those three leukotrienes, C4, D4, E4, are collectively considered the slow reacting substance of anaphylaxis, and they're responsible for chemotaxis of eosinophils, mucus hypersecretion, increased vascular permeability and edema, and bronchial smooth muscle constriction. That leukotriene C4 is the parent molecule and is what is seen within the cell or inside the platelet. Leukotriene D4 is the extracellular metabolite, and it's that leukotriene D4 that binds to the cystenyl leukotriene receptors. And then there's also leukotriene E4, which is the end metabolite and found in urine. These are all metabolically active to some degree, but we focus a lot on the leukotriene D4 for pharmacological reasons. And these receptors also, it's important. The only purpose of this slide is to note that there are different forms of leukotriene receptors, all of which have different functions, some more mediating bronchoconstriction, others more vascular permeability and fibrosis. And this article, which was in the New England Journal of Medicine from several years ago, also posited that there are probably unknown or yet to be described leukotriene receptors. So pharmacologically, again, we have the membrane lipid layer there, and that's where the arachidonic acid lives. This arachidonic acid, as we discussed previously, is metabolized through these different pathways. There's the cyclooxygenase pathway and the lipoxygenase pathway, as you saw. The purpose of this slide is to show you that the corticosteroids work much more proximally in this reaction, and that's why they're much more globally anti-inflammatory. Meanwhile, aspirin and nonsteroidal drugs inhibit these cyclooxygenase pathways, and we'll talk about that a little bit more in a second. And then you have the lipoxygenase pathway here. So this now looks again at specifically the cyclooxygenase pathway. That's important, useful information that there is constitutive and inducible cyclooxygenase. And when we talk about the constitutive, that's that so-called COX-1 pathway, which is a constant low-level production of prostaglandins and thromboxanes also. And these are important for housekeeping functions, including platelet regulation and kidney function and regulation of stomach acid. The inducible COX pathway, or the COX-2, accounts for these acute spikes in prostaglandin levels for pain and swelling and fever and that sort of thing. So one of them is steady basal production, the COX-1. The other is acute spikes, which for inflammation, which is the COX-2. And pharmacologically, these non-steroidal drugs and NSAIDs are inhibitors of both the inducible and the constitutive pathways, while the selective COX inhibitors are COX-2 specific. And it's really important to understand that it's this COX-1 inhibition that seems to be important in the NSAID exacerbated respiratory disease. So what happens when a patient takes aspirin? So when a patient takes aspirin and there's this inhibition of the COX-1 pathway, the bulk of the arachidonic acid gets shunted into this lipoxygenase pathway, and you get this hyper secretion of these cystinoLeukotrienes. And these patients have a constitutive basal overactivity of their leukotriene system that's further exacerbated by the COX-1 inhibition. So these leukotrienes are elevated even at baseline without necessarily the patient having to go take aspirin. The other important point here is that one of the end products of the prostaglandin metabolism is this molecule prostaglandin E2, which is actually anti-inflammatory. So a lot of the pathophysiology is not just this overflood of arachidonic acid down the leukotriene pathway. It's also the lack of PGE2, which takes away one of the anti-inflammatory counterbalancing mediators. So as I said, there's a basal elevation in cystinoLeukotrienes, and this manifests as more of the circulating eosinophils from the AERD patients express more mRNA for the leukotriene C4. There's also elevated levels of that urinary leukotriene E4 that are about 3 to 5 times normal. But after challenge with aspirin or a COX-1 inhibitor, that leukotriene E4, the urinary leukotriene E4, is elevated to over 10-fold normal. So these patients, again, there's a basilar elevation to begin with, and then it's just exacerbated by another order of magnitude when the patient takes aspirin or a COX-1 inhibitor. In the peripheral blood, that manifests as eosinophilia. Both eosinophilic and non-eosinophilic inflammation are amplified by the presence of the eosinophil itself. This is manifested by the elevation of eotaxin, which is selective for eosinophil chemotaxis, as well as the presence of other inflammatory cells like neutrophils and monocytes. In the airway, we also see a lot of eosinophils and evidence of those cells through elevation of ECP, which is eosinophil cationic protein, in both nasal and bronchial lavage fluids. There's a basal increase in eosinophils 2 to 3 times that observed in other asthmatics. And the other phenomenon that's observed is these platelet adherent leukocytes in the polyp tissue. And so these are where you have white cells with the platelets studding around the margin, and there's some interactive effect between the platelet and the chemokines in the lymphocyte that are very immunologically active. And then the other phenomenon seen in respiratory tissue is degranulated mast cells. So these the culmination of these things lead to tissue fibrosis and remodeling. These figures over here just look at the using these immunohistochemical stains here, looking at the combination of the CD45, which is the leukocyte common antigen, and CD61, which is the platelet marker. So you see that the parallel increases in both the platelets and the leukocytes there in the AERD patients compared to aspirin tolerant ones. So this is kind of a complicated slide, but it's put here. One of my partners actually published this in Jackie 3 years ago. It highlights the importance of mast cells. So we have this COX-1 inhibition, the deregulation by the lack of PGE2, the influx of eosinophils, but also basophils and these leukocyte platelet aggregations of the production of all these leukotrienes, these cysteinoleukotrienes, induce inflammatory changes at the level of the mucous membrane. And then with some of these sort of second messengers like IL-33 and this TSLP, there's stimulation of the mast cell. And the mast cell, as we know, anchors the IgE. And eventually there's amplification of the disease process by production of more cysteinoleukotrienes, as well as the typical mast cell mediators such as histamine and other prostaglandins that induce smooth muscle constriction. And so the mast cell is not to be forgotten part of this pathophysiology, in addition to those platelet adherent leukocytes, although frequently when we just look at the tissue or look at the features of the tissue microscopically, the most obvious thing is the eosinophil. But it's really a combination of inflammatory cells. So the leukotriene receptors in these aspirin-exacerbated respiratory disease patients are also overexpressed. The leukotriene D4 is seen at increased levels in the nasal tissue inflammatory cells. But in addition to the increased levels of the receptor, you also have a hyper-responsiveness of those receptors to bronchoconstriction by inhaled leukotriene E4. So the idea is that these receptors are not just overexpressed, but they're also more twitchy and reactive than they are in other aspirin tolerant patients. And again, there's another school. This author is also who published a lot in this area, also posited that there are other yet to be identified cysteinoleukotriene receptors, and wonders whether these are potentially unique to aspirin intolerant patients. So some of the other interesting observations of this disease, the thought that it may be primarily mediated by IgE allergy is something that's been investigated and found not to be true. That it's paradoxical in some ways, that you would think this has some role with IgE mediated allergy, but it does not. Total IgE levels in these patients are only slightly increased compared to normals, and they're actually lower than what's seen in the serum of atopic aspirin tolerant patients. Also, the onset of the disease in young adulthood suggests it's some kind of acquired disease by epigenetic modifications, either through viruses, bacteria, or perhaps inhaled pollutants. And so some of that is at the role of not just allergy, but also heredity or question, and a little maybe counterintuitive, because a lot of these syndromes we tend to associate with heredity. And then again, there's this possible alternative mechanisms that are yet to be described, and it just as there may be alternative leukotriene receptors, there may also be alternative lipoxygenase, one of which that's discussed as 15-lipoxygenase, that are overexpressed in the sinonasal mucosal epithelium. So clinically, this begins with a refractory rhinitis. It can begin anywhere from teenage years to 40s, but the peak is in the range of 29 to 34. And then the rhinitis gives way to sinusitis symptoms with anosmia. Some patients will be diagnosed with nasal polyps at that stage, but usually the diagnosis is established either after the patient starts developing asthma 2 to 5 years later, or even sometimes after they take an NSAID or aspirin and have sudden exacerbation of all of these respiratory symptoms. But going forward, even if the patient never took aspirin or a nonsteroidal anti-inflammatory drug again, these airway symptoms persist. So in the United States, we see a lot of different phenotypes of chronic sinusitis with and without polyps. Probably like a lot of you also see a lot of allergic fungal disease, but we consider this, the aspirin exacerbated disease, to be the most severe phenotype of chronic sinusitis. These patients have advanced polyps as well as CT evidence of disease that's severe. There's plenty of studies showing these patients require more medication use, particularly corticosteroids, and they need more endoscopic sinus surgeries. The aspirin sensitivity is more prevalent in non-allergic polyp patients, which goes along with what we mentioned before, how this really doesn't have anything to do with classic allergic disease. And about 10 or 12% of polyp patients are aspirin sensitive, at least in the databases from tertiary centers. So other features of the disease that are interesting, remember earlier in the talk, we discussed how there are other mechanisms of aspirin sensitivity that are non-respiratory. Well, even though those are classified as standalone disorders, these patients with aspirin exacerbated respiratory disease also can manifest urticaria or angioedema in about 15% of exacerbations. And this is mast cell and histamine mediated. So diagnostic testing is really based on history. Hypothetically, you could try and E4 in the urine, although that's mainly used for research purposes. Regarding history, patients who have a history of one reaction, meaning they tell you that they have had a reaction to aspirin or to ibuprofen or some other non-steroidal drug, if they tell you that by history, 80% of the time they'll have a positive aspirin challenge. In general, up to about 10% of asthmatics will have a positive aspirin challenge. And this in tertiary center databases, it will tell you about 1 in 10 polyp patients also have this aspirin exacerbated condition. What's interesting is that about 10% of patients who think they're aspirin sensitive actually have a negative aspirin challenge. So the histories in the world of chronic sinusitis can be a very variable value, but in this condition, patients who think that they have aspirin exacerbated respiratory conditions probably do, and that's the most important diagnostic step in this case, is to take the good history. When it becomes necessary to confirm the diagnosis, this is done by way of the aspirin challenge, and what happens there is that patients are administered increasing doses of aspirin in 20 milligram increments every 3 hours. If the patient gets to 325 milligrams, which is the adult strength aspirin dose, if the patient doesn't have a reaction by that point, then the test is considered negative. But most positive patients will react by the time they've received 3 doses or 60 milligrams. A lot of times this aspirin challenge is actually not just done as a diagnostic step, but part of a desensitization program that we'll talk about as part of the therapy. Some new protocols use intranasal ketorolac or intranasal lysine aspirin, which is soluble, and there's some thoughts that may be safer. So some reactions that can happen during these escalating administrating doses of aspirin, ocular, nasal, patients can get bronchial spasm or laryngeal symptoms, GI symptoms, that urticaria and angioedema I showed you, or even get hypotensive shock. And so when these patients are being put through this protocol, all of these items you see here need to be available, with the epinephrine being probably the most important, because that's the most life-saving, but also bronchodilators and antihistamines. So the therapy for this is, there are lots of different ones available, but real treatment is multimodal. It's very important for this discussion to be had with patients, that this isn't like coming and getting your tonsils removed, where you have the procedure done and heal and go on with your life. But this is the management of the underlying inflammatory disease is critical, and the understanding with the patient that this really does require a lot of different types of therapies that beyond the time of surgery are protracted out into the long term. So I'm going to go through these in a little bit of detail, describing the nuances, because Most of them are familiar to all of us, but how they integrate together into a treatment algorithm is what I want to highlight here. So the classic algorithm in these patients was to treat them with prednisone for 5 days and then do full house endoscopic sinus surgery, then treat them with prednisone at that same preoperative dose, which is 30 milligrams, and through the first postoperative week, and then taper it to 20 milligrams until the inflammation looks like it's resolving endoscopically, and then taper off it. We put these patients on doxycycline postoperatively, not necessarily because of its antimicrobial effect, but because there are anti-eosinophilic properties of it, lowering ECP and some of these other mediators. Then we also, from the time of surgery, we start patients on saline rinses. And as we taper the steroid, especially once we get below this 20 milligram dose, we have the patient add steroids to the saline rinses. Because these patients are often on prednisone for upwards of a month postoperatively, we do consider putting them on a proton pump inhibitor. In the office, post-surgically, we do endoscopy with debridement at weeks 1, 3, and then somewhere in week 5 or 6. But it's usually at this 3-week point where we also historically have put patients through an aspirin desensitization program. That's when they've healed far enough from endoscopic sinus surgery that we're not worried about them bleeding so much and that kind of thing. It's also about where we're about ready to start weaning them off of prednisone so that we can cover them with the proton pump inhibitor while we put them on aspirin and eventually get them off of the oral corticosteroid. The surgery in these patients, I think it's important to understand that in the U.S. there and probably worldwide, there's been a lot of use of balloon sinuplasty, but for different forms of chronic sinusitis. But this is not a disease which responds to this, and because the removal of the polyp tissue and unloading the inflammatory burden are more important than just dilating the sinus ostia. And the kind of surgery that we do really needs to be more of the old school endoscopic sinus surgery at the minimum. Now, this is just a diagram of the FES that we all know, but I would contend to you that even that is inadequate surgery in these patients, because in these patients, what's more important is the complete marsupialization of the cavity and removing all of the bony bridges. These are also patients where I have a much lower threshold to even resect the middle turbinate, or what I call the full interiorization of the sinus, where we perform modified endoscopic Lothar procedures and take the medial maxillary wall down to the nasal floor. This has two functions. One is that it reduces the surface area upon which polyps can grow, but perhaps more importantly, it also creates wide passageways and conduits for drug delivery. And then there are studies showing that penetration of the frontal sinuses for irrigations and therefore carriage of topical intranasal corticosteroids much better when you do this Lothar procedure. And the same can be said for removing the medial maxillary wall to the nasal floor. So this is the same kind of concept that we have in a patient with cystic fibrosis, where we want to achieve maximum openings, understanding that not only for drug delivery, but also because a lot of these patients probably have a inhibited mucociliary clearance, and so the pathways for irrigation and cleansing can be maximized with these kinds of approaches. So lifestyle modifications, it's surprising to me how non-transparent it is what medications are in certain over-the-counter drugs, and a lot of them do have aspirin and non-steroidal anti-inflammatory drugs in them, and those need to be avoided. COX-2 inhibitors and Tylenol are okay. Other lifestyle modifications are avoidance of alcohol, because this exacerbates symptoms in 80% of the patients. Others have described low salicylate diets, as well as diets that are high in omega-3 and low in omega-6 fatty acids. So this is an example of some of the products which are sold in the United States for headache relief or for heartburn and indigestion. This Alka-Seltzer is it alkalinizes the stomach contents, but it also has aspirin in it. And this Goody's headache powder is also another thing which is popular in some parts of the country, especially in the South, where it contains a mixture of aspirin as well as Tylenol and caffeine. These are all things patients need to be counseled to be wary of and vigilant to avoid. So alcohol, I mentioned, this is a study from Scripps looking at patients with aspirin exacerbated respiratory disease for unknown reasons have reactions with alcohol or exacerbations with alcohol 80% of the time. This is compared to just about 40% in aspirin tolerant asthmatics and about the same 40% in patients with polyps, less or so in chronic sinusitis patients without polyps. But it's also fascinating to note here that even if you just look at aspirin tolerant asthmatics and patients with polyps, that the alcohol is an exacerbating factor in 40% of them, which is a lot, but even more when patients are allergic to aspirin. So salicylates in different beverages can be measured and see how these alcohol, tea as well as certain forms of alcohol tend to have very high levels of salicylate, but the exact mechanism is still not really known about why alcohol does this, because some of these lower salicylate ones have a similar reaction too. Still, patients will want to know this salicylate level if they're going to go on a low salicylate diet, which has been looked at. This is a busy slide. It's the point with it is that you can go to the internet and things like that, and you can Google a low salicylate diet, and it'll tell you what patients to tell the patients to avoid. But when you read the level of or when you read the tables of which foods have high salicylates or even just medium amounts of salicylates, see, this diet can be difficult to follow. It's a lot of common things that are, at least common things that are in the Western diet. But there are some studies, this one from Canada, showing that multi-centered, showing that this can work, that this was a study looking at 6 weeks of a low salicylate diet across 4 sites and 30 patients. Patients had subjective improvement in their SNOT scores and their nasal symptom scores and these quality of life questionnaires. There was also objective improvement that these are polyp scoring and Lund Kennedy scoring, that these also improve. And so there can be some effect for these low salicylate diets if the patients can follow them. High omega-3 diets with low omega-6, that this was a small study looking at this in 10 patients. The diet looked at 3 grams a day of omega-3 fatty acids and less than 4 grams a day of omega-6. Just I'll give you the summary statement that this 3 grams a day of supplemental omega-3 fatty acid is a lot. So this is kind of a extreme way of looking at how to modify the diet. And there was some slight effect on lowering urinary leukotriene E4, but it did have a much more dramatic effect on reducing symptoms with regard to the SNOT-22 score and also improved asthma control. But pulmonary function testing was unchanged. So bottom line is that if you can get the patient to take this much supplemental omega-3 and limit the omega-6, there may be some benefit at in symptom control. So steroids, oral corticosteroids, we know how effective these are in management of chronic sinusitis, and they however have side effects, and there's also for that reason a lot of interest in topical administration. Interestingly, there is one study looking at topical corticosteroids in specifically aspirin sensitive patients, and this was done by Brian Rotenberg in Canada also. That was a double-blind randomized controlled trial in 60 aspirin triad patients, and they did endoscopic sinus surgery, but followed it by one of 3 regimens, either saline rinses with a conventional intranasal corticosteroid like fluticasone, or saline rinses containing budesonide. And they noted no treatment effect in that situation above saline alone. There's a lot of different thoughts about why this was the case. Some think that it may be related to the small effect size. Some think that it may be related to the fact that there may be a greater effect size if you tailor this with a considerate course of oral corticosteroids postoperatively. Some think that the effects of the post-surgical phase and healing may be more predominant and would eclipse the effect of the budesonide. It's really the only study that looks specifically at this, and it didn't work, but it's a practice that we still do commonly because the benefit to risk ratio is thought to be high. So when we treat patients in using that algorithm I showed you before, the typical method in the US anyway of us administering topical intranasal corticosteroids is using budesonide respules. Budesonide, it's actually one of the weaker topical steroids, but the reason why we use it is because it's number one, water soluble, and number two is that it's commercially available as these respules, which are meant to be used in an asthma nebulizer. But what we have patients do is add one of these respules. Usually it's a 2 milliliter dose of 0.5 milligrams. We have them added to 240 cc's, which is 8 ounces, which is also the volume of saline that's in the NeilMed bottle. This has been studied and found pretty conclusively to be safe. That the most sensitive study looking at this was 4 years ago, and it examines stimulation of suppression of stimulated cortisol. In other words, it looked at whether the topical steroids suppresses stimulated morning cortisol. And they found out that in 11 of 48 patients that after multiple months of therapy that it could show suppression of stimulated cortisol, meaning that there was some small potential effect after long-term therapy. But it turned out that the patients in whom that was observed, most of them were also using inhaled corticosteroids for asthma, which we know is bioavailable. Also, these patients who did have this cortisol suppression, that it reverted to normal after stopping therapy for 1 month in 3 of the 4 patients who had follow-up testing. And even though these very sensitive studies did show that some had this suppression of morning cortisol, there was no overt adrenal suppression symptoms or any changes in intraocular pressure. The sum of this data says that if you look very carefully, a certain subset of patients, less than 1 in 4, will have some systemic effect of the topical budesonide therapy. But you have to look very closely for it using the suppression of stimulated morning cortisol study. And it's also associated with when patients are also taking an inhaled corticosteroid. So if that's the most systemic effect we can find, we think that this is safe. So we usually treat patients with these topical intranasal corticosteroid irrigations for about 3 months, at least 3 months, once they're tapered off the oral steroids. Most of these patients are counseled that they need indefinite treatment, and that's important because the compliance with that is of significant effect. There are other options, and all the other options in the U.S. are obtained from compounding pharmacies as off-label mixtures. You can get higher dose budesonide from these compounding pharmacies, betamethasone, which I think our colleagues in Europe use more frequently. Nowadays, if we're going to get a corticosteroid from a compounding pharmacy, the one we go with is mometasone. It is the most well studied. It's also more potent and less bioavailable than budesonide. I think for us, it's available at strengths up to 1 milligram per 100 cc's. And so these topical steroids have also been formulated in different ways using this breath actuated device. And this is something that we're using more and more frequently as well, where it's kind of an interesting little phenomenon where the powdered fluticasone is loaded into the inhaler. The patient actuates it by blowing into the piece you see here, and that propels the powdered fluticasone into the nasal cavity. And the reason why this is sort of ingenious is because when we create a blowing motion, that this also seals the soft palate against the posterior pharyngeal wall, which then closes off the nasal space and allows for the distribution and retention of the drug in the nose. This study looked at this in polyps and found that there are reductions in symptom scores and sense of smell all the way up to the lowest doses studied. And so this was a pretty this is all published now, and it's one of the things that's making its way into our armamentarium as part of the post-operative algorithm. So this is a slide you saw before, looking at pharmacology here. And before I show this to you to talk about pathways where steroids have effects, but and where the non-steroidal drugs have effects. But here, what I'm showing you is that there are drugs which inhibit the lipoxygenase pathway and have been looked at in these aspirin intolerant patients. One of which is called xyluten, which is an inhibitor of the lipoxygenase enzyme. And then there are leukotriene receptor antagonists, such as montelukast and zarafilukast. The thing with these leukotriene receptor antagonists is that their mechanism is to block the leukotriene D4 mediator and where it binds to the cysteinoleukotriene 1 receptor. Those of you that have tried to treat patients with these drugs probably find they don't work that well. And the reason why is that there are multiple other leukotrienes and there's multiple other leukotriene receptors. And so what this does to really slow down the system is very singular and linear. There's some value to using these lipoxygenase inhibitors. I think that they work better than the montelukast type drugs, but it's important to note that these patients who are on these drugs like xyluten need to have their liver function tests monitored because there is some potential hepatotoxicity, which fortunately is reversible usually if patients do have liver function test enzyme elevations. Aspirin desensitization has been sort of a phenomenal thing. Our allergy colleagues figured out that regardless of the mechanism, that if somebody is allergic to something, well, give it to them. And eventually, if you give it to them in small incremental doses, you can induce a tolerance. This is known to decrease baseline symptoms, both nasal and asthma symptoms, as well as improving olfaction. It lessens the frequency of exacerbations and emergency room visits. It lessens the number of sinus surgeries patients need to have, and also the oral steroid needs. So the regimen, there's a lot of different regimens for this. It's very important to have an allergist and immunologist who understands this. And I don't do this myself. I have an immunologist, allergist, well, several of them actually that I work with, and they have their regimens but this is a sample one where patients are given aspirin at increasing doses every 2 hours. In this case, it was 20 milligrams every 2 hours. And then once they get to the baby aspirin strength, 81 milligrams, they go home for the day, and then they come back and pick it up tomorrow at a faster pace. When we talked about the aspirin challenge, it looked a lot like this. And so a lot of times what happens is that when patients are being desensitized, the first phase of it is the challenge. And knowing patients will start having reactions like this, and we're prepared with the epinephrine and the histamines and things like that in case they have a too bad a reaction. But the idea is to start the challenge and then keep going to the point where the patient eventually is on large doses of aspirin that are being tolerated. This is a rapid desensitization protocol, which is done by starting with 1 milligram and getting to a cumulative dose of over 600. And the way this is done by titrating it in small increments actually is by taking Alka-Seltzer tablets, which we talked about before, that have aspirin in it. Once you've diluted those in water, then you can carefully titrate how much you're giving the patient by giving them just small aliquots of the mixed up Alka-Seltzer. The idea here is that by desensitizing the patient over a quick period of time, it can be done safely as an outpatient. That said, depending on how severe the patient's asthma is, sometimes this needs to be done in an ICU. And so this, in the world of what allergists and immunologists do, this is one of the more dangerous things, and it's really up to the clinical discretion whether this is something that can be done in the clinic or whether it needs to be done in a hospital or whether even it needs to be done in an intensive care unit. As I mentioned, that the key index of safety here is the patient's asthma severity. So patients with unstable or severe asthma cannot undergo this. And the rule of thumb to remember is that patients should have an FEV1 of at least 60% predicted, which is in this range or better. As an aside, there's our pulmonology and allergy colleagues classify asthma using what, to me anyway, looks like a very complicated scheme. But I don't think it's important that a otolaryngologist commit this to working knowledge, but I do think it's important to understand that the FEV1 should be at least 60. You'll sound smart to your allergy colleagues, if nothing else. So maintenance doses, these patients, once they get up to that 650 milligram dose, they take 650 twice daily, sometimes for several months. 6 months is a good rule of thumb for there. And after about that point, they can reduce it to 325 twice a day, which again is still 650 a day. During that time, patients need to be wary of gastritis symptoms. They need to be put on proton pump inhibitors. Some of them, a lot of them will get problems with easy bruising or prolonged bleeding during shaving. And a lot of these patients, many of them can't tolerate this and will voluntarily discontinue desensitization. But if you can get that patient to the 325 dose, and then eventually even to just 325 once a day, this will preserve cross desensitization to NSAIDs as a class. The problem is that when you start getting to these lower doses, even though the patient won't necessarily have an exacerbation if they take an NSAID, it doesn't mean that their chronic symptoms of nasal congestion, et cetera, are controlled. So the maintenance dose, we take it from 650 twice a day to 325 twice a day, but somewhere between that 325 twice a day and 325 once a day, depending on the patient, you need to find the lowest effective dose that will control the symptoms. If patients are going to have surgery or some other reason why they need to go off of aspirin, you have to repeat the whole desensitization schedule again from scratch. But it turns out that if you put patients at this 81 milligram dose, the baby aspirin, although that won't be enough to control symptoms, it does preserve the desensitized state, meaning you don't necessarily need, if you can keep them at that dose, you don't necessarily need to repeat the whole desensitization schedule again. That's important because if somebody who's on aspirin, let's say that they need surgery, well, if it's deemed safe enough to do surgery while the patient's on a low baby aspirin sized dose, then that would be desirable rather than having to repeat the whole schedule from scratch, which you would have to if the patient was off of the aspirin entirely for a total of 48 hours. That's a very important point, because if you take these patients off of aspirin entirely for 48 hours to do surgery, for example, you can't just restart them back at this dose because they'll have a massive respiratory reaction. Mechanism of this is poorly understood. There's some thoughts that it might inhibit tyrosine kinases and STAT6, inhibition of IL-4. But one of the other theories is that the aspirin is really affecting its role by its platelet inhibitory function. If you remember long ago, we talked about those platelet adherent leukocytes and thought maybe the aspirin inhibits those platelets and lessens the immunologic reactivity of the leukocytes that are there. So our working algorithm, you saw this before, it's exactly the same slide. But we've more recently, though, we've made some modifications to it. And that has come with the availability of dupilumab or Dupixent. This is a monoclonal antibody that was initially used in atopic eczema and asthma. It blocks the alpha subunit of the IL-4 and IL-13 receptor, which is the same molecule. Patients get a 2 milliliter subcutaneous injection every 2 weeks, and multi-center trials have now been done for advanced polyposis. So this study, 276 patients have randomized to receive either dupilumab or placebo. Again, it's subcutaneously every 2 weeks, in this case for 24 weeks. All of these patients were treated with intranasal mometasone. About 70% in each arm had prior surgery, and the study arm had significant improvements in not just asthma control, but also polyp size, congestion, and the sense of smell. And this was published in Lancet, and so you probably recognize a lot of the names here. So this to us has been a game changer in the management of these patients. And what's different nowadays is that we use saline rinses with a milligram of mometasone in it, which, as I told you, is more potent and also less bioavailable than the budesonide. And it's, instead of aspirin desensitizing these patients, a couple weeks postoperatively, we put them on dupilumab as we start to wean the oral corticosteroids. This is patients who can be trained to just give themselves an injection every 2 weeks at home. Much prefer that than having to be on massive doses of aspirin. Some other therapeutics, there was a time where we used omalizumab, which is an anti-IgE monoclonal antibody. Patients also get subcutaneous injections every 2 to 4 weeks. And there's a dosing schedule, which is based on the patient's weight and IgE schedule, and IgE levels. When it's dosed for asthma, there are studies, some we published, showing that it does improve comorbid chronic sinusitis, lessening prescriptions for both antibiotics and oral steroid requirements. Some other monoclonal antibodies that are available, this is an anti-IL-5 antibody that's approved for severe asthma. Patients get a subcutaneous injection every 4 weeks. And it's also been found to be effective, but this is, I think it's Klaus-Backert's data showing that there are effects that are better than placebo, but there's still pretty substantial symptoms in these patients where they still have significant rhinorrhea and mucus, and that their sense of smell is improved, but it's not down here better. And nasal blockage, again, it improves compared to placebo, but the effect sizes are smaller. So another drug which is immunomodulatory that's worth talking about, mainly because it uncovers some of the mechanisms of nasal polyps that are different than what we think is this drug called ifetroban. And this was originally studied as an antiplatelet drug, as a thromboxane receptor inhibitor. And it was found in the early trials where it was looked at for other reasons, that it reduced severity of aspirin exacerbated respiratory disease. So some of the early studies using this drug for its antiplatelet effect, some of the patients in the studies coincidentally had AERD and seemed to make them better. Again, it's thought that maybe this works through those platelet adherent leukocytes and through its antiplatelet effect. There are studies undergoing now on looking at this specifically in those AERD patients. And it's also being studied for other conditions like diffuse cutaneous systemic sclerosis. Then there's this drug here, which is another one which uncovers some of the mechanistic effects in nasal polyposis and AERD. This is, I can't even say the name of this with my mouth as dry as it is now, but this drug was investigated to treat ALS, and it was found to deplete eosinophils virtually to zero. And so there was a multi-center trial looking at this specifically in polyp patients, 3 of whom happened to have aspirin exacerbated respiratory disease. It's a small study with 16 patients. And after 6 months of treatment, it decreased the absolute eosinophil counts by 94%, nearly to zero. In fact, the eosinophils were below the assay threshold in 10 of the 16 patients. 12 of the patients had nasal polyps that were biopsied, and the number of eosinophils per high power field decreased from 168 to 5. But what was interesting is that there was no reduction in total polyp score, meaning this thing took eosinophils out of the circulation, it took eosinophils out of the tissue, but it did not take the polyp itself away. And so this is right out of their study looking at the massive eosinophil influx in the polyps, and then the same polyps later, but without the eosinophils present. So it's fascinating to me that you can take eosinophils out of the polyp, and that does not, and if you did that very selectively, it wouldn't necessarily take the polyps away. And so that leads us to back to the beginning where we talked about the etiology of this, and that the eosinophils, although they are the hallmark cell type observed, at least in the Western world, the pathophysiology of the polyps and AERD is far more complex. And a lot more of the research now focuses on roles of the mast cells, those platelet adherent leukocytes, as well as other lipoxygenase enzymes and receptors. And so with that, I think I stayed pretty close to time. If there's any questions, I can try to answer them through the chat or however you guys like to do that.
Thank you very much. Thank you very much, Rick. Very nice talk. So if I ask you one question. Let's say you have a patient that comes to you and you made the diagnosis. Would your next step be send them over to the allergist or the pulmonologist, or would you just carry on what you need to carry on surgically and stuff and then send them over?
So nowadays, I work in a building collaboratively with immunologists who are interested in this. And if I see this patient, I will send them to them with the understanding that they go get on the schedule with that immunologist for about 3 weeks postoperatively, or 2 weeks postoperatively, either for desensitization or now more commonly to start dupilumab. The problem is in a lot of communities, there are a lot of allergists and immunologists who don't understand that the polyps need to be removed first because the disease burden is unloaded by removing the polyps. And also if you're ever going to remove the polyps, you need to do that before you put the patient on large doses of aspirin, for example. And so our group, though, because it's a collaborative multi-specialty type thing, they understand that. And so we usually will refer them with the understanding that they'll see the patient again, 2 to 3 weeks after we do the operation. One of the questions was about contraindications to aspirin desensitization, and one of them is, as I mentioned, is severe, persistent, or unstable asthma. The other is patients with gastric problems, stomach ulcers, and that sort of thing. There's about, I don't know, a third or 40% of patients who just can't tolerate aspirin desensitization in some centers, and so it's willingness to comply is another thing too, because patient goes off the aspirin for a couple of days and then tries to take aspirin again, then they'll have a massive reaction. One of the other questions was, so when you're using these steroid rinses, the steroid is added to the saline. The purpose of the saline is usually a 0.6 normal saline mixture, and it's meant to just make the vehicle compatible with the nasal environment so that the patient tolerates it better. And then bicarb is usually added also for that same reason.
Thank you very much for everything, for being with us this morning. I understand you're moving now. Are you on the move?
No, I'm not on the move.
Oh, I thought because I saw that you changed your email.
Oh, our organization changed from .vanderbilt.edu to VUMC.
Oh, okay. So
our hospital, that's it. It's very astute. You see that because our hospital switched its email server from the medical center, from the medical school. Sorry. So very small.